All right, thank you. Welcome everybody to the ACMT and ASM Addiction Toxicology Case Conference. This is the August session. I'm Tim Wiegand. You can see some previous recorded webinars as well as FAQs for some of them through the link that's available through the slides. These are available through the acmt.net /ATCC_FAQs. They're also available on the ASM website as well. I'm Tim Wiegand, Director of Addiction Toxicology and Associate Professor of Emergency Medicine at the University of Rochester. My co-moderator is Dr. Gloria Bashevitz, Medical Director, Strong Recovery, Professor of Clinical Psychiatry, Department of Psychiatry, also at the University of Rochester. And we've guest panelist today, Dr. Mike Holland, who's a professor, Department of Emergency Medicine at the State University of New York, Upstate Medical University, Syracuse, New York. Dr. Phil Moore, Chief Medical Officer at Garenzia Incorporated, Harrisburg, Pennsylvania, and Dr. Ross Sullivan, Assistant Professor of Emergency Medicine, Director of the Toxicology Fellowship at Upstate University Hospital, Medical Director of Helio Health, Syracuse, New York. None of our speakers or moderators have any conflicts of interest to disclose, and we'll jump right into the case. If you have any questions, please use the features on the webinar. Moderators and panelists will also be responding to the questions, and some of them will respond to in real time and discuss. So this is a feature alcohol and sedative dependence and some detoxification and inpatient treatment questions, as well as biomarkers and monitoring for alcohol use disorder. And case one is alcohol and benzodiazepine dependence in a male with opioid use disorder. 45-year-old male presents an inpatient treatment facility requesting help with alcohol and benzodiazepines. Patient completes a phone interview for an area inpatient treatment program a few hours prior to presenting. He has a history of opioid use disorder, but has been taking buprenorphine for about 8 years, 60 milligrams a day, no use, but started drinking alcohol in the last 1 to 1.5 years, initially socially, then daily. At the start of COVID pandemic, reported being prescribed diazepam 5 to 10 milligrams as needed for anxiety, insomnia, and this continued. In addition to the alcohol, wasn't extra, but it was pretty consistent throughout the month. Other than the prescribed buprenorphine and diazepam, there's some infrequent cannabis and prior history of tobacco, not currently, and then taking buprenorphine and diazepam as prescribed, and then just the alcohol. Medical history is hypertension, obstructive sleep apnea, arthritis, intermittent tobacco, but not currently using tobacco, and then the opioid use disorder. A question to the panelists, and they're doing the screening for this type of patient. What additional information is needed for intake and admission for this patient? What information is particularly important in making a level of care assessment? Initially by phone, this is an inpatient facility with capabilities up to ACM 3.7 level of care, medically monitored. And I'll talk a little bit about levels of care initially. So Dr. Sullivan, maybe you can comment on what you'd like to know up front.
Sure. One of the things, and I know we get into a little bit later, is of course the amount of what the person's using, but we're also very interested in what happens when they are not constantly taking this amount of medication. So in other words, what is the history of withdrawal symptoms, the severity of withdrawal symptoms? These are all things that are very important because sometimes a medically managed, almost clinic type based level of care is quite different than an inpatient hospital. So, obviously medical history and all these things are quite important. But, I'm very interested in, withdrawal symptoms and any complications or complicated withdrawal systems symptoms are very important when you're trying to make a level of care assessment.
Okay, great. We'll get that information from the patient shortly here. Dr. Moore, do you have anything you want to add?
Sure. I find it also helpful to find out, expanding on what their history is. Have they tried to manage this themselves? There's more and more providers that are doing ambulatory withdrawal management. Has any of those attempts been going on? Have they tried to detox themselves? And what kind of support systems do they have in place? Some of the environmental questions that increase your ASAM score and need for residential treatment.
Very good, thank you. Dr. Bashevitz, anything you want to add?
Just an estimation of when was the last use and of each substance, and also, what about those social supports? There's a significant other mentioned. Sometimes the patient is not telling you the correct information, but if the significant other can be talked to with permission, then perhaps other information can be revealed.
Yeah, those are good points. I mean, for this, I'd like to know, has the patient been in the hospital recently? Like some of those symptoms that Dr. Sullivan mentioned, has there been prior episodes of inpatient or detox, seizures, DTs, how stable are the medical comorbidities? And then as Dr. Bishevitz mentioned, when is the last use of the alcohol, diazepam, buprenorphine, anything else? And then we'd like to have an in-person assessment, obviously. So the patient completed a phone interview a few hours prior to presenting. He has a history of opioid use and taking the buprenorphine. As I mentioned, describes drinking alcohol in the last 1 to 1.5 years, and that's been escalating from intermittent to nightly, and then some of the days and the weekends, and pretty consistently daily, but mostly at nights. And that's 1 pint to up to 2 pints, or 750 milliliters of liquor, typically some wine. At the start of the COVID pandemic, he was prescribed diazepam, and that's usually 5 to 10 milligrams. Never more than that. Sometimes misses a dose, but pretty frequently. And occasional cannabis. Was heavy in the past, but the last about 2 weeks prior at a social event, but that's not a regular thing. No other substances. In the past history, as I mentioned, is the hypertension. Was on amlodipine for that, obstructive sleep apnea, and arthritis, and then the opioid use disorder. All right, we already talked a little bit about what additional information for intake and admission, and mainly symptom-based. When was the last use? This is just a slide on level of care assessment. Before making a determination about level of care, we need to create a holistic biopsychosocial assessment, which has various factors. This is from the ASAM criteria. Dimension 1 includes the use of substances and withdrawal symptoms. So when was last use? Last use was that morning coming in, and the night before, the diazepam the night before, the buprenorphine the night before. The biomedical conditions and complications. So this health history is hypertension, sleep apnea, and the opioid use disorder. Otherwise doing well, pretty healthy, no recent hospitalizations, no prior treatment attempts in patients, no detox, self-detox a few times, but had returned to use. Emotional, behavioral, cognitive conditions, mental health history has been stable, no significant mental health history. Mood has been off, maybe substance related, but no formal diagnoses. And readiness to change, individuals reaching out in support of his family. And relapse, continued use, or problem potential being seen initially, that would be explored. That would be explored if patients coming in. The living environment is in a family, fairly supportive family, 2 kids, spouse, and working as an accountant, and this got some social supports, which we can talk a little bit about later. So the level of care specific for ASAM ranges from 0.5, which is early intervention, to 4. I mean, Dr. Bishevitz, if you want to run us through the ASAM levels of care and interpretation of this slide, if you are. This program that the patient's presenting to has supports up to 3.7, which is medically monitored. So it does not have the level 4 intensive inpatient or hospital-based detoxification settings. Do you have any, run us through the level of care?
I think one good thing to realize is that not all of these levels are present in every community. So it's really important to understand exactly what's available in your community. So many communities have prevention and early intervention, and certainly outpatient is available in most communities, and intensive outpatient. Partial hospitalization is a little bit more unusual. That's a very intense level of outpatient participation, where the patient stays maybe 5 or 6 hours per day and goes home to sleep at night. Residential and inpatient have all sorts of levels based on the state, based on the definition of community residences, et cetera. So it's important to understand the inpatient facilities, because some of them will do things like manage severe medical symptoms if they have adequate medical staff. Others do not and are less of a lower down on that scale of levels. And then intensive inpatient would be often hospital based.
Very good, thank you. You mentioned partial hospitalization. I've seen that recently coupled with ambulatory detoxification support. So the patient may be doing some detoxification at home with contact either at the facility during the day or even in the evening via phone or telemedicine with maybe the provider. And then they have family or friends or someone that's with them help with the medications at home, but then they are assessed throughout the day, so they don't necessarily need a medically monitored, medically supervised detox or this type of detox. This patient probably wouldn't be a candidate for that with both benzodiazepine, with alcohol, history of opiate uses or taking buprenorphine, but the candidates for that, there's certainly sliding risk depending on available resources and things like that. One of the issues I've seen is the level 4 services are very difficult to find often, in particular if you have to plan for them. If somebody presents sick to the hospital, that's usually one thing where then they may be able to be admitted for detox, and particularly if their substance use is incident to another medical condition, a pneumonia, fall, trauma, something like that. But just presenting with, I'd like to detox, a lot of times that's very difficult to get at bed. Dr. Sullivan, can you comment a little bit about that?
Yeah, that you're absolutely correct. It's very difficult to, admit people for detoxification services to a hospital unless they have a specific designation to do so. And often you are absolutely correct. The patients that we're seeing go to intensive inpatients, in our hospitals are people who have some other medical comorbidity or acute process. And unfortunately, we're actually, due to high demand, we're seeing people unfortunately being delayed to sometimes getting into residential inpatients. And as a result, are starting to have moderate to severe withdrawal. And that's how a lot of these people are actually still getting care, are in an intensive inpatient or hospital setting. Unfortunately, once they're entering, a state of moderate to severe withdrawal, going right past detox, right into withdrawal care. And we're seeing a lot of that. And we actually also seeing people come to us already in a severe degree of withdrawal. Or I'm starting to see even more of that with alcohol, thus requiring a hospital visit. So it's been pretty challenging, and COVID has actually exacerbated all this. So it happens a good amount, unfortunately.
Yeah, right. Dr. Moore, in just a moment, I'll have you comment on the impact of COVID on some of the frequency of your seeing admissions, but planning for a level 4 admission in somebody that maybe has a lot of unstable medical conditions but wants to safely plan a detox coming off alcohol or whatever substance that's maybe not safe in a 3.7 level care. That's the challenge. If they're acutely sick, usually the local hospital and medicine wards, ICU, whatever they need, they would be admitted to that or treated in emergency department and then reassessed. But planning for it just for an elective admission ahead, when would be the safest, and that's often very difficult. There's not very many of these separate level 4. Can transfer maybe from a 3.7 to a hospital if somebody's getting delirium, has a seizure, they're becoming unstable, but it's the frequency of that is very difficult. Maybe some of the attendees want to comment in the Q&A after Dr. Moore comments on COVID and frequency of alcohol admissions. You can see if there's any Q&A questions. And Dr. Bashevitz, Dr. Moore, do you want to comment on your experience with COVID?
Sure. So, we have approximately 57 programs in 4 states. 6 of them are 3.7 withdrawal management. We have programs from level 1 up to 3.7. We don't have any 4s. As Dr. Sullivan commented, they're rare. Some of our 3.7s are the only withdrawal management program within 2 hours. And COVID has been extremely challenging. Our overall admissions have decreased probably at least 50% because of nursing shortages. And then when you have COVID outbreaks on top of that, a 3.7 level of care means that you have nursing available 24 hours a day. And so if you have nurse shortages and combined with COVID, it's really difficult to keep a program staffed with nurses 24 hours a day. So it's not a surprise that our with admissions to withdrawal management 3.7 level of care are just under 3,000 for last fiscal year. And approximately 32% of those have a primary diagnosis of alcohol use disorder, which is an increase, which was expected during the COVID pandemic. And we've been thinking more creatively on how to utilize lower levels of care so that we don't have to have 24-hour-a-day nursing. So what things can we put in place so that we can manage more challenging patients? And because, as I pointed out, some programs or some regions just don't have a lot of options when it comes to residential treatment.
Right. Yeah, no, and that risk and willingness to treat a patient at a lower level, maybe sliding certainly at the start of COVID, downstate New York was really impacted. New York City and other areas downstate, and I had colleagues where their, detox facility, hospital, that had maybe a separate ward where they worked with patients that had 3.7 level support. They were all full. They supported COVID patients, or the staffing was just not available. And so you were just out of necessity would treat a higher level of acuity in an ambulatory setting just because the other detox wasn't available and patients didn't want to go to the ED. Or you had to delay until presentation where patients put off and they had much more severe substance use disorder. Dr. Bishevitz, you want to comment on your experience locally in the Rochester area with COVID?
So locally, the 3.7 facility that I work with had to reduce the bed availability because some of the rooms were double rooms with COVID. So with COVID, they had to decrease them to single rooms. So right away, that decreased the census. And of course, it's been hard to hire people all over the local community. And the state of New York has been doing some things about that, trying to attract people and trying to make it easier to get people retained in the system as well.
Yeah, that's right. No, staffing shortages throughout the system has really impacted support, I think, at all levels. So thank you. Is there anything in the queue before I get on back to the patients? Is there anything in the QA that you want to bring up?
Nothing in there so far.
Okay. All right, audience, if anyone has any comments or questions, please reach out with the QA. Okay, so the patient is brought in by a significant other. At the intake, he's somnolent and lethargic. A BAC is not measuring. The machine apparently goes up to 300, which is quite high, milligrams per deciliter of sleep that arouses the voice, touch, briefly participates, and promptly falls back in sleep. He's not agitated, not hallucinating, but quite intoxicated, oriented to self, able to say the date and day of week and location, but then really quickly falls back asleep. Security areas assist from the car to wheelchair, gets to the facility. Heart rate is in the 80s, breathing okay, SAS 91%, blood pressure is elevated, 160s over 94, and hypertension baseline, not clear what his baseline is. No tremor, not hallucinating, speech is slow, someone slurred in sleep, then he's otherwise sleeping. History confirmed somewhat be the significant other. This is the prediction of alcohol withdrawal severity scale. Some programs will use this to triage whether or not there's a risk for severe withdrawal. Doesn't mean that severe withdrawal would automatically be present, but Maldonado, Dr. Maldonado from, I believe he's at Stanford, had looked at various factors associated with severe withdrawal and has validated this pause scale. The threshold criteria for using the scale is whether there's any amount of alcohol consumed in the last 30 days or a positive BAC on admission. If no, then there's no risk of severe withdrawal. Obviously, if yes, we have a positive BAC in the history, yes, so we move down. This patient been recently intoxicated or drunk. This is just a screenshot of the initial scale, but this patient would be yes, got a positive BAC. Previous episodes of withdrawal, yes, so we'd have 2 points there. Withdrawal seizures, no. This I completed for this patient, no DTs, has gone through outpatients in the past related to opioids, but not for alcohol, has attended some AA meetings separately, Blackouts, no, other than coming in would qualify as a blackout, not able to remember some of the events that morning, combined with other downer sedatives with benzos prescribed, and any other substance use. The cannabis 2 weeks prior to benzo, so that's another yes, positive BC yes. And there's no evidence of autonomic hyperactivity, sweating, agitation, nausea. Blood pressure is elevated, but that's probably baseline here. There's no other signs of autonomic hyperactivity. So he scores a 7, which is a likelihood ratio of 174 for complicated alcohol withdrawal. It does not mean that the patient will have that. So the patient should at least be placed on a symptom-triggered therapy and monitored appropriately. And if you had a score under 4, it suggests it's not at risk for severe withdrawal. Dr. Sullivan, do you use this coming in to the programs what settings do you use the pause?
Yeah. Yeah, we use the pause, or I use the pause, on an inpatient hospital addiction medicine consult. Sometimes we do this when we are thinking about placement. So it's not just necessarily community-based, but also sometimes within a hospital. So, when we try to place people in an ICU, let's say, where we are trying to predict who may have a worsening or severe withdrawal, sometimes I'll use pause in that setting. I do use it myself sometimes when we're in our community-based or 3.7 type of residential services. But even when we do, the way we use it is sometimes for increased monitoring, say. Sometimes it's difficult, as you said, it doesn't necessarily mean they will have these things. And it's sometimes hard to use this when someone's sitting in front of you and they are not altered and they really have a low, say, CIWA score. They say, hey, you have a high pause score, we need to send you somewhere else. Like we said, it's really difficult to get these people level of care. So really it's about knowing what may happen and really putting the safeguards in place for the particular person and increasing the monitoring the best you possibly can. And sometimes, as we mentioned, I think Dr. Moore mentioned, in these 3.7s, there's only a certain degree of that you can get to really, oversee these people due to nursing shortages and staffing shortages. Sometimes there's only so much that you can do. So you have to really use this in conjunction with other pieces of information. Do they need to go to the hospital, or do they need to go to an ICU or something like that? So I never use it alone, but it is an important piece of information with everything else.
Yeah, very good. I think that's how I use it. It's also important for documentation, and I think in your review, it justifies it's important for billing and for insurance purposes. That shows that you've done an overall assessment, and when it's negative, I think it's also when it's very low level scoring, I think it's also quite useful. One of the things that I've seen, is people are struggling with housing, with psychiatric comorbidities. The hospitals are being full. A lot of the, detox settings or inpatient settings, trying to triage whether someone actually has a need for an inpatient bed due to substance use versus mental health, and is it an appropriate place, or is there other factors like homelessness and food insecurity, and that's really prompting the presentation. That can be really difficult. And then, someone overpresents with their symptoms, you've got medications ordered. It's really relying on staff to make the appropriate decision on don't give the meds, holding the meds. There's a lot of subjective reports. It can be dangerous and over-medicating people not appropriate there, or taking beds that are really in need versus, not missing somebody that really needs a bed. So I think there's a lot of medical legal issues involved right now for detox inpatient studies and just trying to triage patients. Dr. Moore, do you have what's your experience with that, and is it getting more difficult and challenging in your perspective, or in terms of triaging patients? Dr. Moore still here, may have dropped. Dr. Bashevitz, do you want to comment on that?
I think in terms of triaging patients, it's always been a little bit difficult because patients and families have their own idea of what would be the best thing. But I think the recent increase in stimulant use has been a factor as well, because that can increase craving, and we can't do a whole lot about that medically. There are some things that work, but it's not universal. So I think this accounts for a lot of dropouts from treatment, leaving facilities against medical advice, et cetera.
Yeah, Dr. Sullivan, yeah, no, I appreciate that. Thank you. Dr. Sullivan, do you have any comments on that? Do you, particularly related to triage and some of the complexities related to, has it gotten more difficult or?
Absolutely. Well, yes, more difficult in one way, but on the other side, almost easier. And what I mean by that is, when I started as a medical director at this Helio Health, maybe 5-7 years ago, when I walked into was a very black and white situation. It seemed like the system was, you admit these people, you don't admit these people. These people with medical conditions, you don't admit. But that's when I first came into it. What I'm realizing as time has gone on, as people and addictions have really, we've realized have encompassed all these other medical problems as well. So triage is difficult because the amount of medical comorbidities and other substance use disorders that go along with them, like Dr. Bashevitz said. I mean, tons of stimulant use. And it's become more difficult. People have a lot of other problems going on. But on the other hand, we've really become much more liberal in all the things that we take. And and people with who have sometimes wound vacs and need certain types of medical thing, like people we as a system didn't normally admit 7 years ago, we are now happily, obviously, and rightfully so, taking these people. So yes, it's much harder to triage in some ways because of the complexities, but on the other hand, we take so many other people that we are taking on some more patient problems, which in some ways makes it an easier system, but it has been more difficult though in the complexity situation.
Yeah, in particular, the psychosocial comorbidities seem to be increasing, and resources are less in the community. We've covered some of these in the past in these webinars, but really severe stimulant use and certainly may warrant a detox monitoring, for unstable psychosis or anxiety, and just a couple of days stabilization before going to an inpatient. Synthetic cannabinoid use has been associated with withdrawal syndromes. Other substances that aren't necessarily going to be screened for, you're just going to be self-report, prescription medications, designer benzodiazepines. There's a lot. The landscape of medications and substances are much more dangerous as well and challenging. You really need to rely on patient report and direct assessment. Right. So this patient's no recent hospitalizations, no previous inpatient attempts, no or formal detox, some self-detox in the past, usually for a couple of weeks to days. Prior seizures, no delirium, no legal issues, substance use. We went over his past medical history, social history, is married to children, good social support, takes an accountant, intermittent tobacco, not currently. Patient's wife brings in his medication, the diazepam, the buprenorphine, and then amlodipine. The counts are appropriate for the buprenorphine, diazepam. There's actually more of the diazepam left in a 10-day prescription. The urine screen shows benzodiazepines, buprenorphine, ethylglucuronide, and THC positive on admission. The BAC is over 300. So from all of the information given at this point, is this patient appropriate for this level of care? What type of detox protocol might you consider for the patient? And then what type of monitoring is generally done in an inpatient, medically monitored, medically supervised or managed setting, and how frequently are checks done? What other types of monitoring for patient safety? And then we talked a little bit about some of the medical legal pitfalls and triage in particular, but if you have any comments on that. So several questions here. Dr. Sullivan, back to you, and Dr. Moore, I dropped off meeting.
Yeah, so
is this patient someone?
Yeah, I think there's two. I think like medical history wise, in terms of the patients presenting actual alcohol use and benzodiazepine use, and the very minor medical history, that portion, yes, the patient absolutely does qualify and should be in a 3.7 type of situation. However, earlier on in the case, we mentioned that the patient was lethargic and difficult to arouse, needed a wheelchair to be transported, and alcohol level was greater than what could be read on the machine. This type of situation in a place that's monitored, in that we may have staff checking on the patient, but we don't have continual, let's say, vital sign monitoring. may at this moment in time may not actually be appropriate to currently be in the detox. And I think about where I currently, the medical director, this type of situation, the patient probably would not be, and the oxygen saturation was 99%, and the patient was very lethargic. If we didn't have a high suspicion that the patient would maybe gain some increased mental status within the next hour or so, this might be someone that we would actually send to a local emergency department where we can get a better sense of some lab work. Maybe there's a metabolic derangement. We know that people who have alcohol problems also have medical situations that arise, like alcoholic, ketoacidosis and other types of nutritional problems, or they can have cerebral, brain bleeding and whatnot. So we would want to get these things ruled out before we just admit somebody who really can't even tell us much. Now, once that's done, and let's say the patient does come back with and everything was cleared, and alcohol level might have been 0.4 in the emergency department or whatnot, the patient was gaining some sensorium back and everything else seemed to be checked out, this person would then qualify for a 3.7 type of situation.
Yeah, no, that's great. I think, there's only some brief mention of he awakens, participates in pulse back asleep. A lot, I think, and also is their ability to walk and stand, even though, he's helped out of the car, and what's the trajectory are real importance. But, depending on the resources and, is there pulse ox available? Is it, he's standing, well, he's not stimulated, or is he really sitting in 90s, even completely just, let alone, and wakes up with touch, or, so those are the things I really want to know as well. Otherwise, I think, watching in the detox, certainly with the sleep apnea, taking sedatives, buprenorphine, alcohol, that makes things dangerous for this individual. Want to know, does he have the CPAP? Is he using it? And this isn't somebody that wakes up and says they're nauseous, you want to give diazepam right away. You really need a careful assessment. Dr. Bashevitz, do you have any other comments? And then what about the type of monitoring, somebody coming in and maybe monitoring for this patient?
So we did have a comment from in the Q&A that it's important also to assess the status of the opioid use disorder. As far as we know so far, it's been stable, but certainly in someone who comes in a very sleepy looking presentation, who needs assistance walking and everything, it's always a concern. What else are they taking? Could they be supplementing either their benzos or opiates with additional street use?
Yeah, those are great points. The screen did not show any different additional opiates. I don't have whether fentanyl was on there or not, but there was buprenorphine positive, there was an opioid negative, but those are excellent points. Or other medications, or is he supplementing with other benzodiazepines that may not get picked up, or in addition to diazepam? The respiratory rate is 16. It's somewhat reassuring, certainly having naloxone available if that's, there's any concern, but those are great points. And then the type of monitoring, go ahead.
Oh, I just wanted to mention the other comment, which I always appreciate grammatical comments. One of the attendees says, it should be noted that we do not actually detoxify our patients. Their body does the detoxification. We medically supervise the patient while they withdraw from the drug. So we're always doing a medically supervised withdrawal, not a medically supervised detox.
Ah, that's a great point. Absolutely. Good. Okay. And then the monitoring, for this patient, there's typically going to be, this patient goes into a detox bed, which has vital signs, symptom-based, nursing assessment. There's no telemetry available. There's standalone pulse ox, I believe that was done coming in, and then staff maybe checking. I got a little bit about that. Medical legal pitfalls we've talked about. I don't want to spend too much time on it, but where I've seen issues is when something bad happens, usually related to either medication or comorbidity, an adverse outcome, unfortunately sometimes deaths, and then the questions the attorney's family has was, why did you have them at this level of care? Why wouldn't you just send them to the hospital? And then then the review is, okay, well, what would have triggered that, and what criteria do you use to send somebody to either a level 4 or level hospital? And Dr. Sullivan nicely went over some of the criteria that he would use, and then also do you have monitoring in place that would have caught a deterioration, respiratory event, or was there substances that were smuggled in and maybe those were used at individual? And so how careful was the assessment, the search, the monitoring to catch, certain things like that. So I've got some of the types of monitoring for patient safety, and then if there is an event review, whether it's just an event of bad outcome, looking at, okay, were these things in place? Were they done? Were they documented? Were if there's electronic components, were they working? Some of these are the vital signs. So it's scheduled, and then frequency may change based on the degree of symptoms. Then there's the withdrawal assessments, which are not diagnostic, but they can be used to assess a trajectory. In this individual, SIWA, cows potentially, mainly to see whether they clinical institute withdrawal of alcohol, the alcohol withdrawal scale. And then there's a medical and counseling assistant checks or behavioral health tech checks. Things they're often referred to somewhat differently depending on facility or state. Sleep night checks, depending on the level of care, medication administration time, and what the patient's symptoms, did they qualify for medications, what were they given, were meds documented. There's cameras in the hallway, often at the nursing station, so if there's a bad outcome, usually I'm requesting to review the video with the patient stumbling, ataxic, coming up to a nurse's station. If they're administered a nursing station, did they get out of bed? Were they seen, walking into the room without any difficulties, and then found, 30 minutes later to appear, without any interventions done or medications given. Some programs may have bed sensors, in particular for a patient like this early on, Sensodyne beds, other type of beds that will send an alarm if there's not movement, if there's changes in vital signs potentially. And then the other type of patient safety factors that are important is the initial screen, certainly that may rule in or rule out the presence of some, doesn't indicate intoxication, just indicates use within the time of detection. Initial search, was it done how carefully? Contraband assessment, some programs in an inpatient program or residents may have, dogs come in looking for contraband, snip, and then regular routine staff search. And then certainly looking at the nursing reports, other reports with patient interaction, what did they document? Clear, oriented, sleeping well, wakes up with door open or difficult to wake up, confused, delirious. So those are some of the assessments. Is anything you'd add to this, Dr. Sullivan, you think is important?
No, I think these are all great points, and all these have to be taken in tandem with what you realistically can do and what type of staff you have and don't have. And we've seen that play a role in almost everywhere any of us on this meeting have worked. We've seen some ebb and flow and bending and to the realities of our staffing.
Yeah, no, in some cases where I've reviewed is, there's vital sign or staff checks, and then you pull the video and there's no one doing staff, so documentation is important, but then, did people actually do that? Or, C was scored, but patients wasn't assessed when these numbers are entered, and you can do it. So the video can be really important sometimes. Dr. Bashevitz, do you have any other questions or comments you want to?
No, I think we've covered it very well with this slide.
Okay. Is any Q&A? Any audience comments?
Nope, nothing new.
Okay, so patients admitted, placed in the detoxification unit of the 3.7 program, monitor with vital signs every 4 hours, although initially actually was given a pulse oximeter, and staff was sitting with the patients as they were, as alcohol level was metabolizing. Let's see what checks were done, couch checks, medications at Q4 hours and based on symptoms, using a phenobarbital taper. When initiated to start when the BAC is under 150, if withdrawal symptoms are present. And I've got an asterisk there, I'm not going to comment now, but some medication protocols I've seen do have this wait until an alcohol level is under a certain level, which I think can be problematic because you can certainly see withdrawal start to begin when somebody's at a higher level, which indicates that they're used to being at a high level of alcohol. And that would be a really big red flag if they start withdrawing an alcohol level. This patient, about 300 or at 300 or close to that would be concerning. Diazepam in the system would be one indication, maybe to send to a higher level. So phenobarbital is 130 every 4 hours or 129.6 for 2 days, then Q6 hours in 2 days, Q8 hours in 2 days, and held a somnolent. Thiamine is administered IM day 1, and then orally multivitamin, and then the buprenorphine naloxone are started on day 2, not on day 1. The patient's labs return as follows. This was done on day 2. The AST is elevated, 152, ALT 137, platelets are 131, FC antibody negative. Blood pressure remains elevated as the patient wakes up. There's nausea, tactile disturbance, disturbing images, eyes closed. Has this very vivid experience he thought his spouse was in during the night, during the second evening, in between med pass, a very real dream. He's asleep. Those reports feeling disoriented, wakes for the first 5 to 10 minutes for the first 2 to 3 days. Day 1 and 2 had difficulty eating, appetite starting to improve. On day 3, labs return with persistent elevation, blood pressure, other symptoms. They add oxazepam to the phenobarbital, and it's extended to help with benzodiazepine detox. Phenobarbital taper slowed to go over 12 days. After the 6 days, it's dropped to 65 milligrams, and then every 2 days dropped by 65 milligrams a day. So it's 65 TID, 65 BID, 65 one day, and then all. Oxazepam is dosed for 3 days and stopped, and some supportive meds, trazodone and melatonin. Phenobarbital is titrated off over 12 days. No meds were held. The patient tolerates this well, is on day 2 and 3, up, moving around, starts participating in the inpatient activities. Oxazepam is stopped. So in general, and I want to get to the second part of this, we have discussion of biomarkers, and Dr. Holland will present. But what is your experience with combined alcohol and sedative dependence? And is this a reasonable treatment protocol, or there's more than one way to certainly treat someone? What is your experience? What types of protocol would you use or prefer? And then maybe comment a little bit on primary medications versus adjunctive agents. And I'll start with Dr. Sullivan. What are your favorite medications for something like this?
Sure. I'll go real quickly. I work in an inpatient hospital setting and an inpatient kind of like 3.7 setting, both very different. In a hospital setting with actually more nursing care, I think it's easier to give adjuncts. It's easier to give them at different time intervals. Things like gabapentin or maybe even valproic acid, which I find valproic acid does seem to help anecdotally with the patients that also have some concomitant benzodiazepine abuse too. It just seems that after the first 3 to 5, 7, 6 days of the acute medically managed services, that there's still some prolonged symptoms, and it seems that the valproic acid does pretty well with that. And then in the 3.7, where we have less vital sign monitoring, we don't have the ability to do, say, every 2 hours CWIS score with the resultant medication administration. Sometimes, unfortunately, even though it's not my favorite, we still do almost a fixed dosing type of regimen because, I live in, unfortunately, the reality of the staffing we have. So vital signs might only be every 4 to 8 hours, and, we get a resultant CWIS score, and we give them, 10 milligrams 4 times a day for 3 or 4 days, for instance, based on initial presentation and initial CWIS score and history. So, these are things, again, because of the situations of staffing and whatnot, sometimes we have to make some concessions. And then also phenobarbital, I have less experience with than, let's say, Dr. Wigan does. However, I do think positively and favorably of it.
Yeah, thank you. Yeah, I really experience in a variety of settings. The main one, inpatient hospital, but some outpatient and other settings as well. And I really like phenobarbital as primary medication. We've covered phenobarbital use in a variety of these previous webinars, so I'm not going to get into too much detail, but I think it works quite well both for alcohol and benzodiazepine dependence. And there's different types of protocols that one would use. This fixed taper with the ability to increase or titrate or hold if there's certain symptoms. Dr. Bashevitz, do you have any favorite protocols or just general comments on medications?
No, I don't actually prescribe the detox protocol because I do psychiatric consultations at these places, which is a very important part of the treatment as well. But I agree with Dr. Sullivan's comments about these things, and sometimes you do need to give fixed dosing. Depending on the staff, it's a very fluid system sometimes. And there's no additional comments in the chat or the Q&A.
Absolutely. I've got some primary medications. Usually you're talking about whether there's just going to be a benzodiazepine-based protocol, a barbiturate, phenobarbital, or combined. Sometimes there's combined. And then sometimes gabapentin I've seen used as primary agent if there's mild and moderate dependence, in particular in ambulatory settings, but sometimes in the inpatient setting. And then adjunctive medications, valproic acid decreases the metabolism of GABA, so you raise levels of GABA as one of the mechanisms, and that is usually secondary to either benzo or barbiturates, phenobarbital, or carbamazepine. And the alcohol use disorder, alcohol withdrawal guidelines from ASAM go through medications and pros, cons in pretty good detail. Gabapentin may be secondary as well, and sometimes used as an off-label use to help with craving. Someone has only alcohol use disorder beyond the detox. I use it in ambulatory detox. Propofol in ICU, usually not just isolated propofol. And then clonidine or dexmedetomidine for an ICU. Clonidine is a sympatholytic, can decrease your overall doses of benzodiazepines, phenobarbital. And neuroleptic secondary, if there's delirium or primary psychosis, we got to be careful if there's DTs not to rely on neuroleptics up front. And there's a number of other things, the symptom-based sleep meds, melatonin, trazodone, thiamine, nutritional support, fluids, carbohydrates, things like that. But those are some protocols. So the patient's symptoms really do improve. Day 2, 3 is never unstable at all. They, report some disorientation, some, not hallucinations, but with eyes closed, some disturbing images. Barb doses were not held. The patient initially at the C was 1115, and then the ixazepam was added because of the persistently elevated C-load with phenobarbital. Day 3 is able to go to some inpatient activities. He's sleeping around 11 at night and stops sleeping many times during the day. And day 4 transitions from the detox meds to the general inpatient bed, and it continues with phenobarbital taper. Patient's not interested in coming off with buprenorphine. Considered disulfiram and camprosate, but the patient suggests that he's not able to take the camprosate 3 times a day. He's looked into it. It doesn't feel, at least right now, disulfiram will be needed, but might consider it in the future. We'll talk a little bit about longitudinal supports as we get to the second part, biomonitoring. I want to jump into that. The patient does well in inpatient setting, and follow-up is attending various meetings, some AA, some other mindfulness meditation-based fitness, counseling, mental health, assessment, primary care, and some family sessions. The program is doing well 1 to 2 months out. I'm just going to jump ahead for monitoring for patients with alcohol. It's just like this patient presents to an IOP and follow-up and brings some labs from inpatient he was discharged with, and he has some questions based on the labs. He wasn't going to get a PEP. Phosphatidylethanol screen done at the program, and he brings this to the outpatient provider and just asks for interpretation. This was done on day 3 and returned positive with a level 1,086 nanogram per milliliter. And so my questions are, what is this? How is it useful, Dr. Holland? We'll get into that in this presentation here. And then on follow-up, you had some other labs done, repeat LPs, so they dropped within 2 weeks to AST 41, ALT at 55, so they're coming down. And then we had the transaminase initially. So this, I've got Dr. Holland, you're gonna join us. I've got your presentation. If you just tell me when to advance, I will do that.
All right, thank you, Tim. Okay, so just a brief talk about alcohol biomarkers. So we have the indirect markers that just measure the ethanol effects on body systems. So they're non-specific and relatively insensitive, and there's lots of other things that can cause them, these elevations. So these are the things you see in the comprehensive metabolic panels. You see elevated liver enzymes and MCV in the blood smear and carbohydrate deficient transferrin. So, but the direct biomarkers are actually minor alcohol metabolites and conjugates of alcohol metabolites. So we have the phosphatidylethanol, the PEF, ethyl glucuronide, and ethyl sulfate. So next slide. So, so the newest of the indirect biomarkers is the carbohydrate deficient transferrin. And I've read a lot about this, but we don't use it in our setting, but it's pretty, it's one of the best of the indirect biomarkers. It's elevated after about 2 weeks of heavy drinking, heavy drinking meaning more than 5 drinks per day. And you keep clicking down. These are common, and there's not, other than the other, what its advantage of the other indirect biomarkers is it's few things can cause the elevations in the CBT, but it's insensitive to binging, because you can imagine, a little bit of heavy binging doesn't, cloud the issue. So it's pretty good. But I don't have any experience with it. That's what I've read about because we just don't use it. Next slide. So the direct alcohol biomarkers are the metabolites. So we have the ethanol is, most of ethanol is oxidized by alcohol dehydrogenase and aldehyde dehydrogenase. And so a very small amount, less than 5%, is broken down non-oxidatively to create these other smaller metabolites. And that's what we're using to measure these other biomarkers. One more bullet. And you can measure these in blood or urine. Typically, for the most of the outpatient settings, it's measured in urine. So this is just a schematic. Ethanol is in the middle there, and 95% of it is metabolized down that gray arrow to the acetaldehyde and acetic acid, which enters the Krebs cycle. Then the ethyl glucuronide is by the UDP glucuronyl transferase, and the sulfosyltransferase to ethyl sulfate. And then, of course, some of it comes out in breath, urine, and sweat. That's why you can smell it on somebody. And obviously, that's why use a breathalyzer to get breath alcohols. Next slide. So ETG, ethyl glucuronide, it's typically measured in urine. And because most of the stuff we do, you can measure this in blood, and it's more accurate in blood, obviously, because when you measure it in blood, it's not subject to, state of hydration in the urine. But it's very difficult for, regular outpatient monitoring for abstinence programs, both with the drug and alcohol, to get blood tests, because nobody likes to get their blood tests regularly. And so it's almost all this is done in urine. It's measurable in very low concentrations. You can detect it up to 4 days. So that's the quote 80-hour alcohol test. It does not distinguish between beverage alcohol or alcohol from other sources, and hand sanitizer use can cause low levels. Next slide. So we know there are some people that are teetotalers, abstainers, that can have low levels, and children can have it. So we think some of it is because intestinal bacteria produce some ethanol in the foods we eat, and that you absorb some, and some of it's there. And there's also small amounts of ethanol in, old bananas, sauerkraut, old orange juice is starting to turn. There's little bits of alcohol, so some of that can be from that. What the most valuable thing we are monitoring abstinence for impaired professionals or people that are a court mandate for either custody battles or for DWIs, et cetera. That's what we use it the most for. Next slide. The measurement concerns are the enzymatic immunoassay, EIA, are unreliable, and there's a lot of false positives. And of course, that's what the little blood spot things that you use are they're just EIA. So that's the problem with the instant tests I see. We don't use the instant tests. We do all lab-based ones. So, but that's the thing, because, so next bullet. All the immunoassays need to be confirmed with LC tandem mass spec, because there can be false positives. Concentrations in the urine vary with hydration, obviously. So if some labs will correct for, and report it as per gram of creatinine, and that's, obviates the need for, figuring out how dilute or concentrated the urine is. Next bullet. The urine should be refrigerated if you're just doing ETG. But next bullet, because you can produce ETG just from fermentation of bacteria and little bits of glucose that can be in people's urine, you can produce ETG, but ETS is not produced that way typically. And so if you're doing both ETG and ETS, which is I suggest you do, next bullet, it does not produce ETS. So it obviates the need for having to, refrigerate these samples. Next. So these are the suggested cutoffs. Somewhere between 500 to 1,000 indicates that this is actually heavy drinking within the previous 1 to 3 days, or remote exposure, or very light drinking in the last 24 hours. And you'd have to get super intense extraneous exposure. Now, 10 years ago when I first started doing these slides and presentation about urinary biomarkers, using hand sanitizer every 5 minutes for 12 hours seemed like, well, that's just bizarre. And then along came COVID, I see people using it constantly all day long everywhere, and we've probably all seen that. So this this doesn't seem that intense anymore, but you can get, some people get into 1,000 nanograms per ml in the urine, depending on how concentrated the urine is, if they're using hand sanitizer every 5 minutes. Next slide. So there's been some studies about it, but one of the best ones, this was just a small study, but they used the 62% ethanol every 5 minutes for 10 hours. You know, so that seemed extreme at the time. And so you keep clicking through those bullets, Tim. They got its urine specimens at the end of each day. And there was a range of up to 2,000 nanograms per ml of ETG in the urine on these days. They did it for I forget how many days they did it for. I think they did it for 5 days. But anyway, they or 3 days. So you can see how that's the mean was, you know, well in a range of somewhere 500 to 1,000 nanograms per ml in the urine. So, but the ethyl sulfate, the ETS, had very few positive ethyl sulfate. Next bullet, and all of them any of them that had positive ethyl sulfate, they were all less than 100 nanograms per ml. So we use 250 nanograms per ml. This is an example of a positive from our thing. And this, you can see that the ethyl glucuronide, the screening and the confirmatory threshold is 500 nanograms per ml. And then if that's positive, it automatically goes to confirm ethyl sulfate. And ethyl sulfate has to be present above 250 for it to trigger a positive. And so then this one, as you can see right down in the bottom of this, like the person's ethyl glucuronide was more than 10,000 and ethyl sulfate was 41,000. So this one, there's a no-brainer. This is positive. So that's the kind of thing. Now I had a negative one I forgot to put in there. The ETG was 560 and ethyl sulfate was negative. So that was theoretically possible to be from a hand sanitizer. So that one was reported as a negative. Okay, next slide. So PEF is the one that we had in this guy. So his came back with 1,068, right?
1,042. Yeah, just above 1,000.
Okay, so PEF is a group of glycerol phospholipid homologs. Next bullet. Keep clicking through those. It's formed exclusively in the presence of ethanol with the action of phospholipase D. It's on the red blood cell membranes, and it has a very long detection window. So if you think of serum ethanol as your blood glucose, and then you can think of PEF as your hemoglobin A1C, you know, because it's tied kind of similar. It's tied to the red blood cell, and that's why it has such a long half-life. It's on the membrane of the red blood cell. It's a direct blood-based biomarker. There's a bunch of species, but they've worked it out that the most common one, the 16 means the number of the length of the carbon chain, and then the number after that is the number of double bonds, I believe is what it is. But these are the two species that are most common, and that's at a ratio of the PEF 16.0 to PEF 18.0. The half-life in the blood is about 4 to 7 days, and it can persist in blood for as long as 4 weeks. And it's present after a few days of moderately heavy drinking. So in other words, more than 4 drinks per day in the average person. And it's perfect for detecting binge drinking. It was not readily available when I first started getting into this as part of our practice, but it is more recently. A lot of labs are offering this, and it's much more common, and the price has come down a lot too. So a lot of places are using it, but in the outpatient setting for monitoring professionals and for people that are court ordered, it's very difficult to get them to agree or courts to order blood tests. So this is just a blood test, not urine. So the commonly used reporting levels, the lower cutoff is in millimoles, it's 0.05, but most places report them as nanograms per ml, which is the same as micrograms per liter. So the low cutoff is 35 micrograms or nanograms per ml, and the higher cutoff is 210 nanograms per ml in the urine. So to give you an idea what that means, light or no ethanol consumption is not going to have anything positive below it's all going to be below that lower cutoff. And moderate social alcohol use might be above 20, but certainly not going to be up at that 210. nanogram per ml level. And then the heavy alcohol abuse, one more bullet. It's going to be greater than a 210 in most of the labs reporting it that way. So it can also be used in abstinence monitoring because it can be detected even up to 12 days after a single drinking event. Now, not one drink, but one single drinking binge, you can still detect it at that very low level. So in people that have to be, for certain law enforcement or military, it's really good for proving pure abstinence. And there's a good correlation with that CDT, the other indirect biomarker that I mentioned earlier. So
that's great. Thank you.
So the one question was on day 3 of this case one's admission, he was 1,068 or something like that. So if you can see with that thing that his is well over the 210, but it's not surprising. He was the history was he's drinking 375 to 750 mLs of 40% whiskey, I think it was, every day, and that's 20 drinks or so a day. So that is considered heavy drinking, and you would expect his PEP to be high, and so I think that 1,000 is not surprising. That would be what you would expect. It would be useful to say after he's gone through detox 14 days to see that that's coming down. You can. But at day 3, that would be you would expect it to be that high.
Oh, that's great. Thank you. And from what I understand, it's a blood test, but it's done via finger stick and not, so it doesn't need to be necessarily a blood draw. It's like a diabetic AccuCheck or something.
That's correct. A lot of one of the major labs that does it, have the blood spot thing that you put the blood spot from the finger stick on the card, and then you wrap it up, package it, and send it to the lab, and they measure it that way. So you're right.
That seems really useful to add to the monitoring biomarkers with ethylglucuronate, ethyl sulfate, intermittently or randomly, depending on cost, certainly. Well, that's a great overview. Thank you. And I just have you've already mentioned this, I'm not going to cover this. We're essentially at time now. This is an example. You mentioned a point of care immunoassay test. This is one type of immunoassay which includes numerous analytes, but you have ethylglucuronate. You can see some of the challenges with this. This faint line is negative, so this is a negative ethylglucuronide test. But compared to the real heavy lines, untrained staff may read this as positive. The only thing positive here is buprenorphine, I believe, at least on this side. But you see light lines are for benzos, amphetamines, and ethylglucuronate. All those would be negative other than a bupe. But so we already talked. Dr. Holland talked about some of the pros and cons. You need to confirm it with ethylglucuronate, with gas chromatography, liquid chromatography, and mass spectroscopy. So that's all. I think we've had a couple chats. We'll take a look at them and can follow up either with email or. Is there any burning comments, Dr. Bashevitz, in the chat or Q&A?
Well, mainly a complimentary comment about how valuable the sessions have been, but also a comment that we should always remember that alcoholics and benzo users can have other medical problems as well, and that sometimes when we're working in a dedicated treatment facility like a detox or rehab, we might not consider these things all the time in alcohol use disorder and other substance use disorder.
Yeah, those are good points, and appreciate the kind words. Thank you. We've got these archived on ACMT and the ASAM websites with watching previous ones. If any attendees are also interested in helping out as panelists, please email either ASAM or ACMT or myself. I think my email is included on the slides. But I end with a final thought. I want to thank Dr. Bashevitz, Dr. Holland, Dr. Sullivan, Dr. Moore for participating as panelists. That was a great presentation. Dr. Holland as well at the end. Thank you. The final thought is from The Sun, recent poem. It's called For Scott, 3 Years Since Your Suicide by Sarah Eva Hansen. I've actually got two final thoughts. The city's arteries burn, another day, another metro fire. So I wait outside the station, the pavement shimmering with heat. It's frustrating, isn't it, how nothing works the way it should. I'm trying to take things in stride, trying to eat different kinds of yogurt and be less angry at the red lights, the pedestrians who always walk too slowly. The days in DC are long, humid, hot as a scorching tunnel, but I know nothing lasts forever, not even summer. The world is more confusing without you in it. If you came back and asked, what did I miss? I'm not sure where I'd begin. I think we might have finally ruined the oceans. When we cut open whales, their stomachs are cornucopias of plastic, a tangle of straws and bags, and fishing lines spilling into the sand. We hardly know what to do with all the crap we've created, but I guess that's nothing new. Maybe I just tell you what was bad has gotten worse. But I'd also want you to know that what was good is still good. Every spring, cherry blossoms explode like piñatas on the sidewalk, and there are a few ripe avocados in the grocery store. And guacamole is still easy to make. Today I saw a baby rabbit in the garden, and the back of its head was lousy with ticks. It made me so grateful for my thumb and forefinger and their ability to pinch. Imagine knowing exactly what is killing you and being unable to even grasp it. I thought you would understand. And then one more is just from Suttree by Cormac McCarthy. Cormac McCarthy wrote The Road and No Country for Old Men, and this is a book that I've been reading. And he's at the middle of the book, he's talking to Regna, and I see strange things in my time. I've seen that cyclone come through here where it went down in the river. It dipped it dry. You could see the mud and stones in the bottom of it, naked fishes laying there. It picked up folks' houses and set them down again in places where they'd never meant to live. There was mail addressed to Knoxville, fell in the streets of Ringgold, Georgia. Seen all I want to see, and I know all I want to know. I just look forward to death. He might hear you, Suttree said. I wished he would, said the rag picker. He glared out across the river with his red-rimmed eyes at the town where dusk was settling in, as if death might be hiding in that quarter. No one wants to die. Shit, said the rag picker. Here's one that's sick of living. Would you give all you own? The ragman eyed him suspiciously, but he did not smile. It won't be long, he said. An old man's days are ours. And what happens then? When? After you're dead. No, nothing happened. You're dead. You told me once you believed in God. The old man waved his hand. Maybe. Got no reason to think he believes in me. Oh, I'd like to see him for a minute if I could. What would you say to him? Well, I think I'd just tell him, I'd say, wait a minute. Wait just 1 minute before you start in on me. Before you say anything, there's just one thing I'd like to know. And then he'll say, what's that? And I'm going to ask him, what did you have me in that crap game down there for anyway? I couldn't put any part of it together. And Suttree smiled. What do you think he'll say? The rag picker spat and wiped his mouth. I don't believe he can answer it. He said, I don't believe there is an answer. And that's it. So their next Addiction Talk Case Conference is on September 2nd, Fridays at 1. So it's the first Friday. We're going back to the first Fridays. Thank you all for attending. And again, thank our panelists and moderators. And if you have suggestions, cases, or would like to participate in panels, please email me. And have a great day.